Thank you.
Okay, thank you, sir. So, in year 2015-16, we wanted to, survey our cases for the post-operative results. So we did a retrospective analysis, and the aim was to find out the residual refractive error in terms of spherical equivalent following uncomplicated cataract surgery. The time I was using the IOLMaster 500 biometer, and sometimes when the IOLMaster 500 did not take the reading, we were using ultrasonic biometry. So almost 10% cases required ultrasonic biometry. The FECO machine used was infinity for all the machines, and all ocular comorbidities were excluded. We excluded the cylinder of more than 0.75 because we are not using toric lenses much that time. So we're not expecting, cylindrical collapse after the surgery. It was single surgeon 2.2 millimeter incision, and the site for incision was selected on steep axis whenever we wanted to exploit the SIA. The ideal formula used as per the axial name like SRKT, Holade, and Heggie. And what we found, almost 15% cases were outliers. They were not within the world standard. And it is highly disappointing feeling to face a refractive surprise and an unhappy patient despite a beautiful surgery. So your experience, a good phaco machine, a good quality lens, and a gold standard optical biometry then was not enough to give good results in 15% of the cases. And the present world standard for cataract surgery is plus minus zero point 0.5 of spherical equivalent. And most of the surgeons identify less than one diopter spherical and residual is tolerated by the patients, but more than one diopter is not tolerated. This was the finding by Benning et al. Which was published in Journal of Cataract and Refractive Surgery in 2012. So cataract surgery has evolved from a rehabilitative surgery to a refractive surgery, as Dr. Maipal already said when he was commenting on the seminar. The high patient expectations due to the refractive surgery, which gives such a good vision nowadays. Environment is highly competitive. Number of premium IOLs implantations are increasing, and patients want better optics and better lifestyle and complete freedom from the spectacles. So why we need an accurate biometry? Accurate biometry, incorrect lens power is still the most common reason for the IOL explantation and most commonly caused by the axial length error. And inaccurate biometry may lead to a variable outcome and compromise patient care. This was again studied and well documented in the study in the Journal and Cataract Surgery by Olson. An approach to a successful cataract surgery, we have two enemies to conquer. One is a spherical component and another is a cylindrical component. The spherical component can be conquered by perfect axial length, perfect keratometry, accurate antechamber depth and lens thickness, and optimized A constants. Cylinder can be conquered with perfect keratometry, surgically induced astigmatism should be controlled, and compensation for the cyclotorsion. When all this is combined, and a correct formula is used with effective lens power calculations, you can get a desired result. So thinking that, and to make most of our cases, as Dr. Anurag said, that any one patient, 99% of the patient or more than 90% of the patients should walk out of from the OPD without any kind of distant correction. So we thought of changing some instrumentations in the clinic. So I got a IOLMaster 700, and very recently, last year only, from January 2020 to February 21, at our clinic, we did again a retrospective analysis to find out the residual refractive error, whether it matches the world standard. So again, the FECO machine used was infinity. All ocular comorbidities were excluded. Single surgeon 2.2 millimeter superior temporal incisions for the toric. Steep axis was exploited when the patient had a very small cylinder and we wanted to reduce that cylinder. Wound modulation was tried. And in all the cases, we used the direct shoot and predicted refractive error was set at plus minus zero point 0.5 diopter. And this is our result of 485 eyes. Now from 15% outliers, we got 9% outliers. In 91% of the cases, we got the desired result. Of these 9% outliers, 44% out of the outliers were due to the improper results with the incision modulation. We could not get the desired result even after the wound modulation. And 31% was the post-toric. When we implanted the toric and we still got some residual refractive error, 20% was the real refractive surprise, and 5% happened in the myopic LASIK. Now, of these spherical equivalent outliers, I would like to clarify that we stuck to the plus minus 0.5 spherical error. That means your refractive error should not cross 0.5 diopter. Spherical equivalent can be 0 with plus 1 with minus 2. Your spherical equivalent is 0. It is not that kind of equation which we want in spherical equivalent when we say it is plus minus 0.5. So this data shows the variation of the spherical equivalent so far as outliers were concerned. So IOLMaster 700 definitely helped us getting the good result. And here is a study which was published in the British Journal about the comparison of a new swept source optical coherence tomography based optical biometer and a time domain optical coherence tomography based optical biometer. The conclusion was repeatability and reproducibility of the swept source optical biometer was excellent, and agreement with the standard biometer was very high. Better lens penetration ability and axial length measurements were obtained with the swept source biometer than with the standard biometer. Another study evaluating the comparison of the new swept source OCT-based IOLMaster 700 with IOLMaster 500. Although the agreement between the two devices were excellent, the IOLMaster 700 was more effective in obtaining biometric measurements in the eyes with posterior subcapsular and dense nuclear cataracts. So this is what we got with the IOLMaster 700 use. Little bit of explanation about the IOLMaster 700, which Dr. Anurag has beautifully covered. I will skip these slides where the multi-zone, 3-zone keratometry with fixation check and B-scan star pattern helps us identify so many factors which you can feed into the newer generation formula and to get the accurate IOL power calculations. Bear with me, I will skip all these slides which are already covered. The IOLMaster 700 gives you so good information about all the data which you want to feed in the recent generation formulas. And the fixation check is so useful. Dr. Anurag has showed that how you can pick up the retinal pathologies when there is a dense cataract. Sometimes your routine OCT machine does not give you any data on the retina examination, but swept source biometer picks up the foveal anatomy so well, and you are saved, and you can counsel the patient beforehand or can refer the patient to a retinal surgeon in time. Once you capture the data of axial length, you can use the best formula, and very nicely my previous speaker is explained how the Barrett shoot helps, and it is one of the best IOL power calculation formula provided by Barrett shoot. And Barrett has proven to be the superior formula compared to Coffer-Q, Holladay 1 and 2, Higgs, SRKT and SRK2 formula. It is also proven to be much better with all the recent generation formulas like LADA Super, Full Monte IOL, Hill RBF method, and depending on and axial length dependent Holladay 1, SRKT, etc. So Barrett formula has the lowest mean absolute error compared to all other formulas. Even when myopia surgery is done, Barrett True K provides the best result, and it is superior to all other formulas evaluated with or without clinical history data available to you. The beauty is the axial length measurement is the best compared to IOLMaster 500 and LensStar, and the induced IOL power calculation error in diopter is minimum with the IOLMaster 700. This part also is very well covered. The multi-zone keratometry and constant spot distance irrespective of the device to eye. gives you very robust keratometry data, and usually it doesn't fail, and any technician can obtain this data without making any error. Whereas in the routine biometers, the change of the distance between the eye and the instrument can change the spot distance and giving rise to error in keratometry readings. So this way you improve your refractive outcomes, and you have the A constants available in the ULIP, which is provided by IOLMaster 700. This is the laser interferon biometry users group, and the IOLMaster A constants are already given to you. It is optimized, and if you use the manufacturer's IOL constant, compared to which the the data provided by the machine is so good so far as the optimized IOL constants are concerned, and you get much predicted results. The machine takes the reading so fast. In just 45 seconds, both the eyes measurements are over. What all you have to do is to focus the cornea in the green cross Myers, and once that is done, and if the machine is kept in the auto mode, immediately the readings are taken. The machine automatically shifts to the other eye, takes the reading in the same way. Once the green signal appears, your data is captured automatically, and in less than 45 seconds, both your results are ready for analysis. This is a real-time video showing you how fast the analysis is available with IOLMaster 700. That. We were discussing about the penetrability of the sweat source IOLMaster 700. In my practice, I have seen that in a month, 2 or 3 times, I was putting the patients on the ultrasonic device to take the measurement when the IOLMaster 500 was not working. Now, after acquiring the IOLMaster 700, hardly any patient I have to put on the ultrasonic biometer, though, as Dr. Anurag said, you have to keep it in the clinic. Very occasionally, when the machine does not take the reading, you have to do it. But there are minimum cases where you have to put, and these data are published world over, and very few patients require the A-scan biometry now. As regards the foveal fixation and the foveal check, which is available because of the sweat source, you can come to know about the macular pathology and can refer the patient to the retinal surgeon for evaluation. And this saves you from the refractive surprises. All this is picked up on IOLMaster, and enough is said about the different formulas and the superiority of the Barrett. One is free to use any formula after having acquired the keratometry and axial length from the IOLMaster 700. I personally use Barrett Fute for all my cases and get very desired results. There are some demo cases. We have found many collateral uses of IOLMaster 700 as a B scan. Many clinics do not have NTA segment OCT, and we miss it very badly. Nowadays, B scan is not available in all the clinic due to the PCP NDT law. So my IOLMaster helps me in many cases, which I'll show you. This is the angle kappa, like chamber depth, iris cyst, patency of YAG PI, the abnormal angle kappa, lenticonus and Descemet's detachment we picked up on our IOLMaster. You can even do meibography on IOLMaster, as infrared is available to you. After doing all the YAG PI, we put the patient on IOLMaster to check the patency of the opening and posterior capsular cataract, and the defect can also be picked up if done properly. So the benefits are, it is non-invasive, compulsory calibration at the startup. The moment you start your day, the machine automatically calibrates, and then only you can proceed with your work. Extremely less operator dependent, 45 seconds as we see for the measurement of both the eyes. Excellent inter and intra-operator repeatability. no discomfort causing bright flashes. Exact intensity of the fixation target is 660 nanometers, and non-harmful sweat source illumination. Moreover, now what is available to us is total keratometry, which is replacing the assumptions with the measurement which is available in the Barrett formulas. So you can now use the actual total corneal power. After having realized that the posterior corneal curvature plays a spoil spot and all your toric calculations results are not up to the mark, with the rule anterior corneal astigmatism correction was resulting into overcorrection, and against the rule astigmatism was giving you undercorrection of the toricity, which is now overcome with the anterior corneal axis, which is considered different to be from the posterior corneal axis. And IOLMaster, because of its multi-zone keratometric data and the intracorneal distances, produces 3D picture of the corneal thickness, and it gives you the exact corneal power, total corneal power, which otherwise you have to obtain from pentacam or intraoperative abrometry or Cassini if you are using. But this is a very handy instrument now, which gives you the total cornea, which you can feed in any of the formula and can get the true toricity power. So now we are not we are having the Barrett TK universal tube and Barrett TK toric included in the machine, and it takes the corneal measurement in the same time. Within 45 seconds, both the eye data is captured without taking any extra time, and this does not require any hardware change. It is available as a software upgradation in the machine, and it is proven that the biometric the total keratometry data or total corneal power improves the toric IOL calculations, and a lot of studies are available now to state that total corneal power inclusion results in lesser and lesser surprises in the toric power following the surgery. The total keratometry posterior corneal surface can now be directly measured with sweat sourcity and used in formulas on board the Zeiss IOLMaster and ZCalc without changing your clinical workflow. And thus it is no longer necessary to use assumptions or nomograms of the posterior cornea. This improves the results of toric IOL power calculations, and 14% more patients are, the outliers are now within plus minus 0.5 diopter cylinder. So now we are replacing the assumptions with the measurement. Zeiss IOLMaster 700 has no hardware or operating change, proven telemetric keratometry and sweat source OCT, used with trusted formulas on the Zeiss IOLMaster 700 and existing IOL constants. Two new Barrett TK formulas for non-toric and toric IOL is available now, and it improves the toric and non-toric IOL power calculations. Not only this, if we have the keratometry, I mean the topography available along with the keratometry, you can verify your steep axis. So now the IOLMaster 700 is available with central topography, which provides you a very good information about the corneal curvature in the central optical area, and corneal irregularities in the central optical zones are regarded as visually relevant, which you can pick up from the same machine. Again, this does not require any hardware change. It is done with the same machine by upgrading the software. No changes in workflow. The IOLMaster 700 now measures the central corneal topography, and it provides anterior and total axial power maps designed to detect visually relevant corneal irregularities. So just with one machine, you can work so well, and the entire data which you want to get the correct results is available. So now, in total, the IOLMaster 700 offers you 6 Barrett formulas: the Barrett Universal 2, Barrett Toric, Barrett TrueK, Barrett TK with Universal 2, Barrett TK Toric, and Barrett TrueK with TK. So With this, I sign off. My topic is very well covered with Dr. Anurag, and I don't personally have the experience of the TK because TK requires to change my IOLMaster formula from Barrett to Higgs, which we have been working because the imaging system does not have the TK, and that is why two machines don't talk to each other. But there are a lot of studies, at least the one which I came to know, which was published last year, says that the TK gives much better results compared to the other formulas when you use along with the Barrett calculator. Thank you very much.